We have Dr. Geller here with us, and he's going to be discussing the initial diagnosis of skin lymphoma. Why did it take so long? He is an associate attending physician at Memorial Sloan Kettering in New York. He has also been doing a wonderful job of helping us do some translations into Hebrew. We're trying to expand our publications into multiple languages, so he has been very helpful with the foundation doing that. And if you come to our bi-monthly Q&As, he has done one for us. He'll be doing another one for us at the end of the month. So if there are questions that he doesn't get to today, when we get to the Q&A portion, we do have another Q&A portion tomorrow, but we also will have him, is it the 26th? 26th. Him and Dr. Gioni will be doing an hour block for us to answer questions. So we're going to turn it over to Dr. Geller because I know you're here to see him. So thank you, Dr. Geller.
Thank you. Thank you for the kind introduction. Thank you for inviting me. So I always like to work with the CLF. I think it's a great foundation. I think there are many other patients with other conditions that really look up to this foundation and their activities. And this is really a good example of how unifying forces can actually make a difference. I usually tell my patients who are recently diagnosed that they are diagnosed with a disease that now it's going to be like a marathon. It's a long distance run. It's not something that is going to be short. And part of it, and I don't know how many of you are currently or in the past, did long distance running, but it's all about the mental issue. It's not a lot about the physical. It's about the mental. And with that, the CLF is doing, the Cutaneous Lymphoma Foundation, doing so much that whenever they reach out to me and ask for something I can help with, I always say yes. I never say no to them. So also for this presentation, I immediately agreed, and I suggested this topic because I believe that this is a topic that really becomes an issue in the discussion, in the first discussion, in the initial visits of patients coming to MSK with a new diagnosis or suspected cutaneous lymphoma, mycosis fungoides. Patients come after they started looking up the Google and seeing all these horrible photos. They're really scared, and then they start to look back and say, wait, I have this for so many years, for many of them. How did they miss it? And if they missed this diagnosis, am I in higher risk of having a worse outcome now? Is it something that I should blame someone for? So this raises a lot of tensions, and because of that, I think it's very important, because I think this is actually this delayed diagnosis is actually one of the hallmarks of this disease. I think it's part of what making it also difficult to cope with, at least at the beginning of managing this disease, because always there is this question, is it truly that? I mean, sometimes we have patients after being diagnosed for a year, we started treatment, and then they come, but they did say it was eczema for so many years. Maybe it is eczema. Maybe it's not mycosis fungoides. And, and we have some scientific tools nowadays to prove what it is. But again, nothing in medicine is 100%. And for some patients, they still, negotiate with the disease and negotiate with the physicians. And also for us, it's always good to go back and not to take anything for granted, and to revisit things, even if they were made. I was taught when I did my derm residency, even if you have the head of the American Academy of Dermatology coming to you and this is his diagnosis, you always question. You start from point zero and you make sure that you treat the right disease, because diagnosis is the basis for the treatment, right? So because of that, I thought it was so important to talk about that. I have no relevant conflicts of interest regarding this talk. And usually when we speak about the diagnosis, you all know it's a clinical pathological correlation, right? You need to have a biopsy. You need to have a pathology saying, I see here lymphoma cells, and this is suggestive or confirmatory for skin lymphoma, and from there we can start rolling the ball and understand exactly what type of lymphoma, what stage is the lymphoma, what markers it has, and then to decide on the treatment plan. But for many patients, it takes something like years before someone actually does the first biopsy. And this is not unusual. And then you have the patients who have had like several biopsies along the years, but they are non-conclusive, or they were called inflammatory conditions, psoriasis, eczema, different conditions, until there is one point that there is one biopsy, and then they discover it was all along, or maybe not all along, but the thought is maybe it was all along the way, lymphoma that was missed. But it's not that easy. Sometimes there are patients who have both diseases, both eczema and lymphoma, or eczema that over time evolves into a lymphoma. It's not something that is frequent. We'll talk about that later, but it can happen. Long, chronic inflammatory conditions, whether it's on the skin or it can be also internal. Yeah, for example, gastric cancer can evolve from gastritis, long gastritis. Because of that, we treat H. pylori, right? Because H. pylori, the bacteria that you can have in your stomach, if you don't treat it, eventually it can transform into a malignancy. So we know that chronic conditions can eventually evolve into a malignancy. So looking back and say, okay, they missed it all along the way, it's not necessarily true. And sometimes we do ask for patients to bring or send over, or we reach out to the pathology departments and get the previous slides, sometimes from 20 years ago, and we re-review them, and sometimes we don't find lymphoma on these biopsies. It was, at the beginning, it was eczema or psoriasis or some reactive process, and probably later on, these abnormal clones, these abnormal T cells emerged from this chronic inflammation. And we have literature showing also the pathways that are involved. And this is something for another talk, whether we can prevent this or not. This is, another issue. But regarding the diagnosis, this is also a very common pattern that we get. And then we have the pattern of patients who get a biopsy done, but the biopsy is not that conclusive. And then we are still struggling. Do we need to wait and to do another biopsy, or can we start treating that as lymphoma? I mean, patients frequently come to Memorial. At Memorial, we always repeat the review of the outside biopsies. So we have our pathologist, because there are a lot of overcalls, so we ask the pathologists at Memorial who are very familiar with these conditions to review the biopsies before we move forward. So this is usually, when I get to see a new patient, I already have our read of Memorial of the Memorial pathology who are experienced with that, have a read of the slides, which is, for me, it's more reliable than looking what outside. Not that outside pathologists are not good, but we are talking about a very rare disease. For majority of dermatologists, they see 1 or 2 patients like that in a year. They have maybe a few patients that they treat over time because it is a chronic disease. Most of them will see what's more common: eczema, psoriasis, fungal infections, acne, all of these conditions. Some of them overlap both clinically and also pathologically with cutaneous lymphoma, but not all of them are aware. And I think outside awareness is the most important thing. Being aware and humble. If you see that what you thought, and I'm skipping maybe to my bottom line of this, which is mainly addressing like the outside pathologist. If you see that what you thought the patient has doesn't respond to the treatments you give them, it doesn't behave like what you usually see and what usually is reported, open your mind, be humble enough to say, maybe I was wrong, and do a biopsy or refer to someone else, okay, who knows that better. Because we know it's very tricky, and we have these tricky cases, specifically nowadays, and I don't want, to overload you with too much information, but specifically nowadays that we have such sophisticated treatment for eczema and psoriasis. And you don't need to go, you can just watch the commercial for the Super Bowl and see everybody becomes like a pharmacologist nowadays, right? You get to see all of the medications that are out there, all the adverse effects, everything, and they keep having them, and this is like a huge market. But some of these medications are very effective when they are treating inflammatory conditions, but by changing the immunological some immunological pathways, they also change the way cutaneous lymphoma behaves. Some of them even drives it forward and make it more aggressive. And that makes also diagnosis a bit more complicated. Because sometimes for us it's much easier to get a patient to say, okay, I had this rash for 5 years, a biopsy was done showing lymphoma, I'm sent here for your opinion and let's move forward with staging and then treatment. Then a patient who says, I've been having these 5 years and they tried this, that, these immunological, and then you start thinking, do what I see now actually looks like what it looked when he just presented with the initial rash? Or do I see also some effects of the treatment? You can have side effects of the treatment. Some treatments, even for psoriasis, actually they make psoriasis a bit worse in some cases. So it's very difficult nowadays. So the main issue is to understand that this is complicated for everybody. Also for the centers that do that, in my clinic, it's 90% it's cutaneous lymphoma. I do another 10% of like rashes due to immunological or chemotherapy at Memorial Sloan Kettering, but majority is just cutaneous lymphoma clinic, working with our radio-oncologist, hematologist. It's a multi-center, multidisciplinary clinic that we have in our center. And even for us, there are some patients that I say, it looks to me clinically, by looking at you, that this is lymphoma. I cannot prove it on the pathological level. So we need to think how we move forward with treatments, because, I won't start anything that is a chemotherapy or something more aggressive for a diagnosis that is not clear. So it's very challenging, and some patients truly require this. Like I had a patient on Friday saying, one of the dermatologists told me he doesn't believe it's lymphoma, and he thinks there will be, he will need like at least 7 more biopsies to prove that. I mean, there are these numbers that, how in average, how many biopsies it takes to get to the right diagnosis. And it's not because someone is wrong in interpretation, but it's just that this disease is quite tricky to tease out from other more frequent diseases. And I want to touch this without getting too much into, basic science, but this is like how skin looks like, and I will try to maybe show here. So the upper layers are like the epidermis, and then underneath it you have the dermis, and you have this blue loop here. It's like the blood vessel. And usually what we see, and this is normal skin, we see lymphocytes in the skin. And this is, some patients, it's very hard to explain. I mean, I don't know how many of you here are like newly diagnosed patients, but it takes sometimes a bit to understand, because some patients are told that they have skin cancer, some have like blood cancer. There is a lot of confusion. What exactly do I have? And I usually say, in medicine we separate that. We say liquid tumors or blood cancers are the ones that you have in the blood. Lymph nodes are included with that, and bone marrow. This is like the hematopoietic system, the one that produces blood and blood cells. And then we have the tumors that are considered solid tumors, because there are tumors of the specific tissues, like prostate tumor or breast tumor, colon cancer, etc. And then when you have like a melanoma, it's a malignancy of the skin, of the melanocytes, which are part of the skin. With cutaneous lymphoma, it's tricky, because we are talking about a malignancy of blood cells that are present in the skin. So the cells themselves are part of the hematological arena, but they are hosted by the skin. And they can go also from the skin outside through the blood vessels. And this is usually what happens. These cells, their purpose is to fight antigens, is to create immunological reaction against antigens that can be present on bacteria, on allergens, on fungus. Different exposure, different triggers can cause these cells to accumulate in the skin. And also on a regular basis, if you take like a biopsy from anyone, you'll find some T cells in the skin, because this is what they're supposed to be. They're guarding, they're there. And if you have an inflammatory condition, then you have more and more of these cells showing up. And then you have normal cells in a larger number, And once these cells are becoming abnormal or have like features that are not of normal cells, which are malignant cells here in the darker blue, then we call it cutaneous lymphoma. But it's very hard sometimes to tease out, even if you have a lot of cells, how much is this a lot to call this lymphoma? And how much changes in the cells do you need to call this lymphoma? And this is on the pathological and the mechanism basis. Because if you have like a stage that is really like tumor stage, this is like how tumor stage looks like. So you see much more cells. This is easy. This is not, and usually the issue is not with delayed diagnosis for patients who have advanced disease, right? Sézary syndrome, when they're red all over, when the skin is erythrodermic, or in the cases that it's tumor stage disease, that are actual like lumps on the skin that are protruding. This is easier for the pathologist to say, what's going on here is not a reactive process. It's not like psoriasis. The issue is differentiating between these cases, the cases that it's not really, here it's like normal skin, but you have a bit more than that. If we had like more bluish cells over here, then this is how eczema looks like many times. But the cells are looking, the appearance is of normal cells. And for pathologists, it's sometimes very hard. There is no certain marker and no certain like genetic alteration. Now we are in the genetic era. And there are some conditions that once you do genetic testing and you find specific alteration, and then you say, okay, I have this, so that means this is the diagnosis. We have certain lymphomas that it's like that. You get like the cells, you analyze, you see there is like a formation of or a mutation of merging of two chromosomes or two cells, and then we know this is the disease, this is diagnostic. We don't have any diagnostic tool to say this is lymphoma versus this is a reactive process. And to make it even more complicated, you can see that even here, when you have like this is like a representation of a patch or plaque stage, you see these lesions, and the next one is when it's like a tumor stage. So you have here more of these cells. This is like more like heavy plaque, and this is like more the patch one. And you see you still have these bright blue cells, and they are like representing normal cells. And that's because once you have malignancy, and it doesn't matter if it's lymphoma or other cancers, once you have a malignancy, abnormal cell, the immune system recognizes these cells and tries to attack them. You know that alterations that are pre-malignant happen in everyone all the time, but in the majority of the cases, the immune system manages to get rid of these processes and to destroy these cells before they become significant. And when you have and because of that also some of the immunosuppressive drugs and conditions, they cause or may enhance this process of cancer progression or cancer development. But in the majority of the cases, you have immune cells that reduce and eventually eliminate the process of cancerous change. And also when you have the disease already going on, the cancer already starting to proliferate, you still see the immune cells are trying to fight the cancer cells. And for those of you who follow other malignancies, you know that this was like the major breakthrough that was done with melanoma, right? Melanoma, the treatments that nowadays we have for melanomas, and they were tried also for lymphoma, but are not as active as they are in melanoma and in other cancers, are the ones who are PDL or PD-1 inhibitors. These are actually, they're not fighting the cancerous cells, but they're fighting the way the cancerous cells are evading the immune system. Because the cancer cells, they know how to evade the immune system, and that way they manage to proliferate. If you make a way of these cells to be more susceptible to the immune attack on them, eventually the cancer goes away. So these are like the new mechanism, are more use of biological treatment to recruit the immune system to fight better against the cancer cells. And we know now that also some of the more advanced treatments for CTCL are actually working not only on the cancer cells, but also working like in other routes, also on the reactive process. And we call this tumor infiltrating reactive cells, because they are infiltrating the tumor, these cells. But think about the pathologists. Pathologists, they get a slide. It's filled with lymphocytes. It's very hard to say which of the lymphocytes are actually the bad ones and which of them are the good ones trying to fight the bad ones. And there are some ways of doing that. These are the markers. Probably all of you got these like very confusing pathology reports with all of these like curses, CD4, CD8, CD3, loss of CD3, loss of CD7, all of these. And these are the markers that usually we see they differentiate, because you know lymphocytes, you have different lymphocytes. You have B lymphocytes, T lymphocytes. They mature over time. So they have certain like, this is, I would say it's like the thumbprint of these cells is their markers that they have on their surface. So once we know what are the markers, we can know what type of cells these are and whether or not they're normal or abnormal, okay? Because even in T cells, we have different cells, right? We have T helpers, we have T regulatory, we have T cytotoxic. It's really an entire, you know, milieu of different cells. But eventually, in order to make sure what we see is truly lymphoma, you need not only to do the hematoxylin and eosin, which is looking at the overview of the slide, how the cells are in the tissue. We need also to do immunohistochemical stains, and we need also to do clonality studies. I'll talk about that later. I'm sure all of you heard about that. Some patients, they don't want to go too much into it, but from my experience, usually patients who come to these conferences, they are the ones who like to read and learn more. So yeah, so I'm trying to get the balance between getting you to fall asleep after lunch and keeping you awake. So we spoke about this difficulty under the microscope, and you know, and there is also a lot of communication between us, the physicians and the researchers, learning this field and the fields of inflammatory conditions, because again, eventually it's the same cells. And we do believe there are overlaps also that can benefit us for the treatment options. And we know that some treatments are not suitable for, you know, for CTCL that are currently in the market for atopic dermatitis and psoriasis, but there are probably some pathways that are mutual and can be used for things that are, you know, overlapping. For example, the significant itch that you have in CTCL. Eventually, when you look into what is triggering itch in CTCL, it's very similar to the same factors who are active in atopic dermatitis. And there are some very good treatments for itch control nowadays for atopic dermatitis, for eczema, that we are trying to see if they can be also used for CTCL, again, without causing the CTCL to become worse. And so it's, a lot is going on. I have some patients, and probably some of you are like this, that keep sending me whenever there is like a new approval from the FDA. And I love it, because this is, you know, I learn from my patients, and I will never argue with a patient that, you know, they tell me something about the skin. I mean, they get to see it. I see it once every 3-4 months, or more frequently if things go wrong, but they see it every day and several times a day. I don't, you know, patients, they're, you know, they know themselves the best, and they know also what to research. I never, you know, I always like to get information from my patients, whether it's about their specific disease or some ideas that they have. And there are like stories. I think they had like recently, I don't remember exactly, this family, the father who found like the medication for his son who had this genetic disease. There is a movie about that, who like digged into that. I don't remember what is the diagnosis of the son, but yeah, I mean, I truly understand that, and I really appreciate that, and they got that. I mean, there is like a new anti-itch medication approved for eczema. Like within 2 weeks, I got one of my patients sending me, "Have you seen that? It's approved. Why won't we try that?" I told her, well, it's good. It's good that you are up to things, but we need to make sure that we don't make more, you know, we don't complicate the disease, because in her case, it's already very complicated. But I am open to new ideas, and I think that this is the way to try and combine forces. And actually, it's interesting because in recent, there are there are CTCL meetings, like the ones for professionals and the medical field. So there are also ones for eczema. And in recent years, we started to merge forces, and we have, before the eczema meetings, we have one day or half a day that we bring also the CTCL experts, and we discuss it together, because eventually there's a lot of, overlapping. There are other overlaps. There is overlaps with autoimmunity, with lupus and certain cutaneous lymphomas. So there is a lot that we need to be open to other fields, not just to be too focused in our, a tunnel vision. We need to be open to other options of treatment and development in the field, dermatology and medicine in general. Let's go back to clinical. So I believe I managed to convince you that it's not easy when you look at under the microscope. And I think that also, and now I will try to show you also how the clinical presentation is quite difficult. But let's go to the numbers. So when we think about the outside dermatologist, I mean, for me, these numbers don't work, right? I said 90% of the patients have CTCL. Everything I see. I go in the grocery store, I see there, someone has a bit of eczema. I think to myself, does he have CTCL? Everything is CTCL. After I have residents spend time with me, they say, oh, now it's going to be so hard. Every patient I'm going to see in the urgent care, it's going to be CTCL. Rule out CTCL. I tell them, right, but this is my purpose. It's that it will keep some of your, brain cells will be marked with CTCL. It will be somewhere, it will be there. So it hopefully will pop up on time before things get worse. And again, we know to say when you should start thinking about CTCL. But the common patient who comes with an eczematous rash, eventually it is psoriasis or eczema. You see, psoriasis, we're talking about 3% of the American population has psoriasis. And atopic dermatitis, on adult population, in younger it's even higher, we're talking about 7%. And cutaneous lymphoma, I mean, the numbers change, it depends on what subtypes, etc. But when you take entirely T-cell lymphomas, we're talking about 14 cases per million persons per year. So these, every year for a population of 1 million, there is 40 new cases that are diagnosed in the US. And to prove that even on more in a better way, I put here, this is a great study that showed the overlaps, also clinical, but also under the microscope. And you can see, so we have CTCL versus psoriasis, 2 patients, and CTCL versus atopic dermatitis. And they managed to pick distribution and presentation that is very similar. And this is biopsy confirmed. It's very hard to tell. It's very hard, and I don't expect, and even myself, sometimes I tell the patient, I give it 80-20, that this is CTCL in patients who, versus some inflammatory conditions. Sometimes it's hard to tell. It's a matter of distribution, how these lesions evolve over time, what triggers them, family history. We try to put everything together. History of allergies takes into account as well in eczema and psoriasis. We know these are more familial than CTCL. Sometimes some blood work can help us with that as well. In atopic dermatitis, there is a lot of eosinophiles and other markers of allergies. So we try to put all of this clinical information together, but it's still very, very hard to say. And to make it even harder, again, like I said before, there might be patients that some of the lesions are psoriasis and some of them already emerged into lymphoma. Again, this is not something common. It's not that these 3% of the population will eventually are at higher risk of lymphoma, but we do see patients that have both. Because when you have a disease that is 3% in the population, out of these 14 cases per million per year, there will be some of them that also have psoriasis. And that will make it even harder to diagnose their disease. So we have a patient coming with this rash. to a dermatologist. What do we expect him to do? So it's not necessarily to run and do a biopsy. Usually we do, if the clinical presentation is clear-cut and it looks like eczema or psoriasis, I mean, I expect them to start treatment. We don't need to do biopsy for every patient with an inflammatory condition. And eventually, it's most likely that this is like not one of the zebras of the T-cell lymphomas. It's more like of the more common diseases, right? So it's inflammatory condition. And this is also what new dermatologists are taught. Think about what's common for this population, for this age. And in pediatric patients, it's even harder, yeah, because pediatric patients, eczema is very, very common. Every pediatric dermatologist, every second child who walks into the clinic is eczema, so he needs to be very alert of the possibility of CTCL, which is much rarer, but it does occur also in pediatric patients. And then I would expect to start treatment as eczema and psoriasis. I would say that there are no criteria or no requirements before starting immunological therapies to verify the diagnosis. And this is something that we as CTCL experts, we do think that this is something that should be done. I mean, eventually a skin biopsy is not a sophisticated or high-risk procedure. Every clinic can do it, and eventually the idea is just to rule out cutaneous lymphoma before you start a medication that might cause a flare-up of this disease. So this is one of the topics that are in negotiation between CTCL experts and eczema experts, trying to get to understanding when is the right time to do a biopsy as a routine in a patient who has eczema or psoriasis, right? So I don't think, for example, pediatric patients should get who are thought to have eczema should get a biopsy, because the chances of being a patient with CTCL are extremely low. I would start treatment and follow on them. And what even is more important to remember is that at the early stages, if we are not talking about erythroderma, if we are not talking about tumors, we're talking about early stage disease. Mycosis fungoides is stages 1A, 1B, right? Less than 80%, just patches and plaques. Then the treatments eventually also overlap. So starting a patient on light therapy or topical steroids will eventually treat either options. So, and this is, by the way, also maybe one of the reasons why some patients are never diagnosed, because they are thought to have eczema, they're sent to a local, like, photo clinic, start phototherapy, disease responds, and then if they flare up, they go again for phototherapy or given some topical steroids. Nobody ever does the biopsy. Everything just is quiet. That's okay with me. We know eventually mycosis fungoides early stage is an indolent disease. Majority of the patients, right, about 90% we are talking, will have no advancement into an advanced stage disease. Will have normal lifespan. We can do whatever they want. There is not something that is like triggering the disease from the outside. Can travel, can work, can have family issues. Everything is going to be the same, right? And I don't know if you're a physician, we at MSK, we say to the patients, because many patients come, will it kill me eventually? We usually say, you will die with it and not due to it. It's a chronic disease. We cannot cure it, but we can manage to get it under control that will allow you to live your life without disturbances. This is the purpose of this. We cannot make it go away. We also don't have proof that treating in the early stages will prevent disease from progressing, because nobody actually took a group of patients and said, we are not treating them, we'll see how many of them progress, and we treat another group and see, this is not ethical, like, study that you can do. We do know, and I have patients that sometimes I had enough, I don't want any treatment. And some of them never progress. They just have this fluctuative disease of rashes coming and going. Some of them do progress. It's hard to say if that is because they stopped treatment or, it's always the road not taken. We don't know what lies ahead in this road. So it's hard to tell. We as physicians, we tend to say we have a diagnosis of cutaneous lymphoma. If it's early disease and we have good treatments that are not causing harm, like light therapy, local therapies, topical therapies, we do suggest to use them and to treat the disease because it should eventually prevent the progression of the disease. To tell you, to give you a reference what it's based on, we don't have a reference that shows that if you don't treat the disease will progress. We don't have anything like that. But we know that when disease is progressing, then we need to treat because the disease can become aggressive. So for this, and we are talking mainly, again, the main issue of diagnosis delay is in the patients with early disease. It's not the patients with advanced disease. For them, usually it happens quite fast, and that's because the biopsy is done. Biopsy and blood work are done quite fast. So for these patients, again, it's okay with me, and it's always also like reasonable to start treating what's common, to treat it with the treatments that are accepted for these conditions, but to keep being alert to the fact that if the patient not responding well to the treatment, then we should biopsy. And because of that, I put this here. When to biopsy? This is, I think, the most important. This is what I try to teach the residents and fellows who come to me. This is the most important thing, and that's, I think, the issue that sometimes caused the delay in the diagnosis. It's when you start to see that patients develop unusual presentation that doesn't look like eczema, and sometimes it's not even something that you can put into words. In these patients, and in the clinics, academic clinics that work with eczema patients, sometimes they say, it doesn't smell like eczema to me. Something here doesn't smell. I need a biopsy. I want to do like a PET. Something doesn't work for this diagnosis. But again, for the outside dermatologists working in large clinics, sometimes they have a few minutes for every patient. It's sometimes easier. I don't blame anyone. I worked in clinics in the community also. Sometimes, you hear the people outside. You need to keep going, and then you just switch from one treatment of psoriasis to another one. But at a certain point, you need to take a step back and say, do I really treat psoriasis here, or do I do a reevaluation? And this is really important. So if the rash worsens, if the lesions are changing the morphology, if a patient always had like pink scaly patches, and now he starts developing more thick plaques, then you need to think that something here is progressing, that it's not the eczema that was thought the patient had. If there is no response to treatments, like patient doesn't, usually eczema responds very well to topical steroids, to light therapy. Again, I said also CTCL responds to that, but if a patient doesn't respond, and of course if patients have other symptoms, losing weight, fevers, because of that it's always important. When we teach dermatology, you are a physician. After that, you are a dermatologist. Always ask about other symptoms, and other symptoms can be things like losing weight, fevers, night sweats, but can be also sometimes other things like headaches, etc. We know that CTCL, usually when it goes inside, it goes to the bloodstream and lymph nodes, but we know that there are also rare cases that disease can involve other organs. And we need to be alert and to remember that we need to look at the patient holistically, not just the skin. If you are a dermatologist, it's right that you are here for the skin, but you're here for the patient's skin, and the patients come first. So you need to ask the patient about other issues that he's troubled or have issues with, and try to see if they are connected. Sometimes they are not connected, neither with the disease or the treatment that you're giving. And then I think you should make sure that he's getting the right, referrals, and gets to see whoever. I don't expect the dermatology to understand about how to manage headache. But if a patient is getting headache and you gave him some retinoids that can cause headache, you need to know that this might be also, your responsibility. So it's very important for that, and I think it's a lot of education, and we're trying to get there. But it's always a struggle. Specifically nowadays, med students, they are so bright, but there is so much knowledge outside, and it's very easy to be it's like a vacuum. It's endless, the information about the cells and the level of cellularity and pathways, but you need to zoom out. You have a patient in front of you, This is the basic, how you speak to the patient, what you get from the patient, what the patient is conveying to you, not by words, by his like, the mood that you have in the room. This is the important thing, these are the stuff that is super hard to teach in med schools. And this also, when we try to pick our residents every year, this is the hardest, because they come, everybody like with their hair and their suits and everything, and you try to get the understanding. I mean, I'm sure they're all brilliant, but are they human enough to be physicians? This is so hard, and this is like, there is no, and I don't buy AI, won't replace that. Because of that, I'm not afraid of AI, because these are the things that, eventually you need someone to speak to the patient, and these are the things that are so hard to teach. But it's a holistic thing. You need to understand that. So when we get to the point that we say, okay, we need a biopsy, so we already know this is not going to be the definite, result. In many patients it is. In many patients, by the biopsy, we get to the diagnosis, but in some patients, we do need to remember that pathology can overlap between lymphoma and inflammation. Biopsy may show dominant inflammation against the lymphoma cells. I mean, the patient might have lymphoma, but his immune cells are so active that it's very hard, even in the sophisticated ways that we have in clonality testing, and I'll speak about that in a minute, but it's so much reaction is going against the lymphoma that it's hard to tease out the lymphoma cells. A biopsy might be taken from the wrong place or non-active place. I mean, again, with biopsies, it's a lot of communication with the patients, because you need to biopsy the right place. Some patients come, it's either that they don't want the biopsy or they don't care about doing a biopsy, but some of the patients, they have terms. They want the biopsy, but it should be done from this and that, and this is how it should be done. Okay, I have no problem with the numbing, with everything, but choosing the treatment, the lesion that is going to be biopsied is super important. And it's very important to do that. And this is something that many times it takes some time to explain to the patient. The last thing I want is to do a biopsy from an area that I know in advance is not going to give us any additional information. If this is I'm making harm than good, I won't do it. If I need to do a biopsy, I need to do it from this lesion, and this is the reason. And usually I try to show them in a picture. This is how your disease looked like. Now it looks differently, etc. I know we have a few more minutes. Yeah, getting there. No. We talked about getting the mood from them. Reading between the lines. Also, I'm married enough years to get this mood and between the lines things. So what we can use, and what I believe all of you saw in your biopsies, is to do this clonality testing, and there are different ways of doing clonality. And this is like, I'm sorry about the reference, but this is like amazing photo, but it's from a veterinarian journal that I found it in. Because also dogs can have lymphomas. You know that? You can have mycosis fungoides in dogs also. So clonality testing, what we do is actually when we have inflammatory conditions, so it's like what we see here, the inflammatory T cells are all over the place. They're trying to fight different, like antigens, which are like the surface proteins on whether it's a bacteria or even a cancer cell or an allergen. They try to fight them from different angles. And you end up with this process that is polyclonal. You have different clones of T cells in the tissue. When the disease is becoming more dominant, then you start having these more red cells here, which are the cancer cells. And eventually they become like a clone that is leading. And you can see that unlike a reactive process that you have many T cells of many kinds, in lymphoma you have one T cell that comes from one mother cell, and this is the type of cell that is the dominant. And by the way, with clonality, we're also able to track down disease along the way. So if a patient, for example, had first a disease that involved only the skin. At a certain point, he has lymph node. We can look into the lymph node and see if the same clone is the one that was on his skin. Because sometimes there are patients who develop another lymphoma that is not associated with a skin lymphoma. So this is like a way to see if this is the same process, yes or no. There are some patients who develop multiple clones over time. It's very complicated, but this is one of the ways of trying to see within the biopsy if this is more tending to be a lymphoma or inflammation. And when that doesn't work, we need to think about repeating biopsies, although we don't like it, and many times the patients also don't like it. But sometimes we have no other choices. And we would try to take it from different morphologies. Again, because it's not only if the lesion is new or active, it's also a matter of how much anti-tumor activity there is in this biopsy site, because sometimes there will be so much fighting against the tumor that it will be hard to track the tumor in this biopsy. I have like 5 minutes. I have two. Okay, yeah, 2 papers I have here, and I thought it was nice to put them like back to back. One is the initial diagnosis of skin lymphoma, the provider side. So this is a study that was done. It was like a survey that was passed between 44 dermatology healthcare providers, PAs, NPPs, physicians, and you can see the main question that they asked there is, when do you include the cutaneous lymphoma in your differential diagnosis? So 91% said that they do it when treatment of a common skin condition has not been successful. So this is actually what we are trying to teach, and I think that 73%, they are saying that this is what they think about, that even when they see the rash before treatment, 66% when the rash appears in sun-protected areas. You know that in lymphoma, we tend to say that it appears more when the sun doesn't shine, and 25% include CTCL when making a differential diagnosis, like any time. But this 91%, it's like, and again, we still have this 9% that will continue to treat the same disease even if it didn't fail and don't think about CTCL. But the numbers are encouraging. CTCL often goes undiagnosed for years. If you have treated patient or patients with skin condition or diseases that were eventually diagnosed as CTCL, what skin disorder was the patient treated previously? So you see 75% it was for atopic dermatitis, 63 was for allergic reaction, 52 for psoriasis. Then there is par psoriasis, which is like a unclear definition. I don't know if any of you got this diagnosis. And then fungal infection, drug reaction, so things that are much more prevalent. When you have suspected a new case of early CTCL, what has been your usual course of action? So majority of the physicians, and that's good, I think, they start by treating it themselves. And again, in early stage disease, this is a disease that definitely can be managed by outside dermatologists. You don't necessarily need to see a referral center. And then 34, like a third, refers to a center that specializes in cutaneous lymphoma. So I think we are getting there with a like acknowledgement of CTCL, but there is a need here. You can see there are conclusions. Eventually, there is increased education of CTCL is needed for dermatology community to improve patient outcomes. And this is another study. This looked on this patient side. And this is like a study from the British Journal of Dermatology from the UK. They looked, they picked 19 patients and did like a very thorough interviews with them about the impact of the disease on their quality of life and like life in general. This was done back in 2015. Since then, we have a lot of other studies also looking into these issues. And in the recent meetings I've been attending, there are usually like sections for quality of life. And nowadays, quality of life became one of the parameters that when a trial is being started, this is one of the requirements also by the FDA to show that the drug is not only efficacious on the pathological level and the clinical level, but also that there is a difference in quality of life. Because it might be, a drug might be great and get like 50% clearance of the body, but if the 50% that remains still bother the patient in the same way, so for the patient, it didn't do 50% improvement, right? It did much less. So nowadays, and there are like specific questionnaires for lymphoma and lymphomas of the skin that are used, and these are usually requirements by the FDA nowadays to show it's not only effective on the classically medical aspects, but also on the quality of life. So they picked 19 patients, different stages of CTCL, interviewed them. Time from onset until diagnosis ranged from 4 months to 47 years. And the majority did report, and this is also what I see in clinic, that the diagnosis, this rash that was eventually called lymphoma, was there for something like 3 to 7 years. And all 19 patients described some delay in obtaining the correct diagnosis, reported initial misdiagnosis, most frequently as psoriasis, eczema, occasionally as dermatophyte, meaning a fungal infection or insect bite. And they bring some of the quotes of the patients. They say that a correct diagnosis was welcomed, but the disease but one patient said that she was happy about getting the diagnosis. I can maybe even read it here. So she says, when I was diagnosed, I was in shock, and I was also in revelation, because I thought I had, at last I really know what I have. And this is something that, some patients feel relieved to get like a diagnosis. Because of that, sometimes when biopsy comes unclear, it creates some tension in the room, because some patients say, not again. This is like, I want results and I want answers. Sometimes I hope I managed to show you that due to all the effort, sometimes it's the matter of this disease. It's not that we don't want to get there, but we still don't have like a good diagnostic way to tell apart. Hopefully in the future we will. But it is like the frustration is mutual. Also for us, it's very hard. Because on the other side of like not diagnosing CTCL is the fact that we don't feel in these patients that it's like unclear, like a wishy-washy diagnosis. We are not also feeling comfortable to start them on the very good treatment we have for eczema, because we are afraid that if it is CTCL, it will get worse. So sometimes this like condition that is in the middle is really frustrating, as holding back both the physicians and the patients. But this is like a summary of what we discussed. I won't go over that again. And you're welcome to reach out to me. I'm available also at MSK website. I have a LinkedIn which follows, things, talks I give and stuff. You can always reach out through either ways. The foundation has my details always on the site as well, so you're always welcome to reach out to me. Yes, we have questions. Yeah.
We are recording this, so if you want to go back and look at the slides and then also be able to grab the contact information off of it, if you're not getting a good photo, we will have this out on the Foundation's YouTube channel.
Yeah, and end of April, we're doing the Q&A, so you can also hold your questions, and I'll be there to answer.
So real quick, this whole concept of centers of excellence, I think that's a tricky one, because when you go looking for centers of excellence, they're not all created equally. Some have large staffs that are only dedicated to CTCL. Some may have one physician, either an oncologist, hematologist, and a dermatologist. There has to be a way, two things. One is to allow people to put in very specific things that they're looking for in the search. And second, how do you educate providers, dermatologists, and other first-level physicians to have the courage to say, you need to go to a center of excellence? Because that kills you it's time. And a lot of these centers of excellence, you got to wait a couple weeks, months, or whatever. And anything that creates a delay, to me, is a huge obstacle. So I don't know how you resolve that.
Yeah, no, I think these are all very good points. I think that the centers of excellence, eventually, I think they are given to these places that you have at least some of the physician or few physicians. You said there are sometimes even one physician who dedicates his time and efforts to better understand cutaneous lymphoma. You need to understand that in the area of dermatology, probably you know, but in dermatology, but also in hematology, this is considered as it is a rare disease. It's considered as a really area that very few physicians are, get the experience and expertise in. So I think the number of physicians is not really the thing. I do agree that there should be a way to tease out which centers have the multi-centered or multidisciplinary groups, because this definitely makes a change in my opinion and my experience. When you have in the same room, you gather the hemato-oncologist, the dermatologist, radio-oncologist, all sitting together, talking together, making the plan together, it looks a bit different, even if you are in an excellent center, having to see one and then start to move to the other one and then make another appointment. So I do agree. Maybe there is a way to put in the site which ones are multidisciplinary. Again, not all patients need it. Patients with 1A disease usually don't need this multidisciplinary and can have just a good dermatologist who is very familiar and knows what to do with cutaneous lymphoma. And I think it is challenging, this issue. We, specifically at MSK, we do try new visits to get them. We usually do some triaging based on the pathology report. The ones that do appear to have a time-sensitive matter, we usually see them within 2 to 3 weeks, not more than that. There are cases sometimes that are a bit delayed, but also we need to do some analysis of the pathology before we get to see the patient. So
We have an online question.
Yeah.
So Dr. Geller, this is a little off the topic, but related to treatment. What are some best treatment responses for itching?
So eventually the itching is part of the disease. So the itch should get better if the disease is under control. So, and that's also a way for us to see if the disease or if the disease is overcoming the treatment or the treatment is not as effective. Sometimes the patient will say the itch is back, and then the rash starts to come back. So I think eventually it's treating and then we have good ways of trying to treat the itch separately, which are based on topicals. There are some good medications. The issue with medications against itch is some of them cause to be a bit drowsy. So gabapentin, and there are others like some patients are given antihistamines, mainly if it's during nighttime. But there are some treatments that are specific for itch. But the issue is we need to see that it still keeps the patients under good enough, I would say, the adverse effects are not bad enough to cause them discomfort, because it is very tricky. Eventually, for us at MSK, we usually know that if the itch is not controlled with the regular treatments, which, like I said, are antihistamines, gabapentin, we need to step up with the treatments for the disease. So it will make us choose maybe a more potent or higher doses of the treatment the patient is getting. Also light therapy is another modality that sometimes treats both the itch and the rash, but takes a bit longer. And nowadays we are studying also the effects of radiation. We give quite frequently total skin radiation at Memorial, and the effect on the itch is very significant. The issue is with radiation, you need to give some maintenance, otherwise the rash and the itch comes back quite quickly. So, yeah.
Quick question. So, because our T cells develop in our thymus, is there any research out there that indicates for us who get this diagnosis, was there some sort of mutation or something that happened to the T cells in the thymus as they were developing?
Yeah, I mean, the thymus is an organ that is mainly active during childhood, and when you grow, it eventually it becomes smaller and eventually dysfunctional. We do look into we don't have any evidence that these, if there was some alteration or triggers for this disease, it was something in childhood. Again, we see patients, sometimes they develop this in their 90s. And we have my youngest patients are 4 and 5 years old. So it has, and we do try to see if there are any genetic alterations. And like I said before, unlike other lymphomas and in other cancers, some cancers we have very, very noticeable and very significant mutations that are associated with disease. BRCA, for example, in breast cancer. We didn't find, and there are several centers doing it separately, both in the US and in Europe, trying to find if there are any genetic alterations. Probably it plays a role, but the role is not, it's not only a genetic issue. So there's still a lot to do with that. We're now looking into that also at Memorial. We try to see, I didn't mention at all of that, but there are also some racial disparities. Disease behaves much worse and develops in a more aggressive stage in earlier ages in patients of African American descent. And we are trying to see on an ancestry basis now to see, because it's very hard just doing based on patients' reported race to do analysis. So we try to see if there is anything associated with that. But again, this disease we see all over the world. I was trained in Israel. We have both Ashkenazi, Arabs, Muslims, not Christian. It doesn't differentiate between people. You have it for everyone, kids and adults. Yeah, unfortunately, it's still there's a lot to learn, a lot to be researched. We do have better treatments nowadays, I think, than we had 10 or 15 years ago, mainly for the more advanced stage. And this hopefully will get even more better in the next years. Yeah.
All right, we have we're going to do one last question, and as Dr. Geller mentioned, he will be doing a virtual answers from the experts at the end of the month, and we will also have some Q&A tomorrow.
Thank you again for the presentation. I guess I wanted to know, I know that the population is usually found in much older generations, but have you seen an increase? I'm 30. I was diagnosed last year with stage 3, so I'm advanced staged. Mm-hmm. Have you seen an increase of patients within my age range getting this at later stages? And do you feel like the efficacy of the treatments that we have now show up a better prognosis? Hopefully that's my question.
Yeah. So for the first question, I think that we all along the way, we saw that the dominance is patients in their 5th and 6th generation. In decades, these are the ones that we get to see most likely to be diagnosed with MF. But pediatric patients and young adults, it's something that is definitely not a rare, presentation. We do see that. My impression, and also we have a database that is a national database for cancer reports, which is called the SEER database. There is a lot of studies done on that. If someone is interested in epidemiology of these diseases, these are the best resources. It gathers something like 1/3 of the US population. The states there report mandatory all cancer, including mycosis fungoides, CTCL, to this database, and there are a lot of studies done on that, trying to see exactly like I said before, between different races, age groups, genders, to see if there is any differences. I would say that I can say that when I moved, I worked in Israel, like I said, what I was very interested to find out is that when I moved here, I saw much more patients diagnosed at earlier age who are African Americans or higher skin types. And this is what made me also look more into that, and we are doing several studies on that. In Israel, we have we have Sephardic who are not as dark skinned as the African Americans here. We don't see any differences between them. And also when you look into the literature around the world, you see there is not much about other races, but might be that there is some association. Maybe we thought also it might be also, we talked about delayed diagnosis. Sometimes patients with higher skin tones, it's it's harder to detect it in the early stages, because not all physicians, and nowadays also I'm involved in this, on this side, we're trying to get more and more patients to be like more and more like providers to be aware of the different presentation of skin disorders in darker skin types. And one of the things that need to be done is also to make sure that the educational material, textbooks, have good representation of both black and white colors, right? Because some of the diseases originally, you don't get that, integrated into the medical educational system. So we're working on that as well. And these are also things that hopefully will increase the awareness and maybe make diagnosis easier. So.
All right, thank you, Dr. Geller. That was wonderful. If we want to thank Dr. Geller for being here
Thank
today. We really appreciate it.